All right, it's a couple minutes past the hour, so I'm going to say good morning and good afternoon to everyone. Welcome to HDSA's research webinar series. I'm Dr. Leora Fox. I'm the Assistant Director of Research and Patient Engagement at HDSA. I'm also joined by Dr. Eric Johnson, HDSA's Chief Mission Officer. And today we are here to discuss the Vibrant HD trial with two leaders at Novartis and clinical experts who were all involved in the branaplam trial. And I'm going to introduce them in just a moment. First, I want to remind you about how we do Q&A at HDSA webinars. So first, our panelists are going to be making a presentation, and then they will address questions after they present their slides. However, you can type your questions into the chat box in your Zoom toolbar at any time. And a reminder that this is a closed chat, so only HDSA and our panelists will be able to see what you have asked. Once again, we've got a lot of people attending live. We'll get to as many questions as we can. And if we aren't able to answer all of them today, then you're really welcome to reach out to HDSA really with any question anytime. And we'll do our best to help follow up with the help of our panelists if needed. We are also recording today, so if you want to watch this presentation later on, or you want to send it to somebody else, you can go to hdsa.org/research-webinars, or you can go to HDSA's YouTube channel using the button at the top of our homepage. Usually it's up in a day or two. We try and get that up as soon as we can. So just to share some different kinds of upcoming webinars and services at HDSA. You can learn more about these by joining our mailing list. You can check out hdsa.org/research webinars and hdsa.org/disability chat. That's another series hosted by HDSA's resident disability attorney, Allison Bartlett. If you're interested in other types of information about HD or any social services, you can see what HDSA has to offer at hdsa.org/support. And if you want to help support the programs that we offer to those affected by HD, you can visit hdsa.org/donate. For specific research info and opportunities, you can follow HDSA's social media and our research blog. You can also go to HDSA's hdtrialfinder.org to learn more about currently recruiting clinical trials, as well as our surveys page, hdsa.org/surveys. And there are lots of ways to contribute to HD research from home there. And now I am very pleased to introduce today's speakers. We have the clinical program head for the branaplam program, Dr. Harry Ramos, Senior Clinical Development Medical Director at Novartis. We have the medical lead for the branaplam program, Dr. Beth Borowsky. She's the executive director and senior global program clinical head at Novartis. We also have a Vibrant HD clinical site investigator and chair of the trial steering committee, Dr. Blair Leavitt. And he's the director of research and a consultant neurologist at the UBC Centre for Huntington's Disease. So thank you to all three of you for being here to address the community directly today. And I'm going to hand it over to Novartis and to Beth to get started. Stop sharing my screen for a moment. So welcome.
Great, thank you. Wait for the first slide to come up. Perfect. So hello, everyone. And I'd like to start by thanking everyone at HDSA for both organizing this event. I know these things aren't easy, and for giving us the opportunity to speak to you today about recent events in our development of branaplam for Huntington's disease. And I'm happy to be here with both Doctors Ramos and Leavitt today. So if we can go to the next slide. This is just our disclaimers, you can see here. And we'll get into the discussion on the third slide now. So I'd like to start by kind of giving you a big picture view of the history of branaplam development. So branaplam was first discovered by Novartis scientists as an oral drug for treating a rare and fatal disease called spinal muscular atrophy, or SMA for short. And then a few years after we started clinical trials in infants with SMA, we learned from one of our dog safety studies that branaplam had the potential to cause neurotoxicity. So at that point, we carefully reviewed the data from the ongoing study in SMA, and then we modified our protocol to include additional assessments that could detect neurotoxicity if it appeared. And then after that was when we discovered that branaplam could actually lower Huntington levels in Huntington's disease animal models. We also demonstrated that it lowered Huntington levels in the SMA children in our study. So at that point, we began discussions of these findings and the potential safety risks with a panel of Huntington's disease experts and advisors, and then began a clinical trial called Vibrant HD in people with Huntington's disease. And as you'll hear about more today, the study was really designed to detect the earliest signals and signs of neurotoxicity, as well as other safety measures. And then in August of last year, we paused dosing in the study due to safety concerns. And then in December, we made the difficult decision and announced the termination of development of branaplam in Huntington's disease. So we never did see clear evidence of neurotoxicity in the SMA study, and that study completed at the end of last year after more than 7 years of treatment in some children. So if we can go to the next slide. So now that you've seen the history of branaplam, let's talk about where we are now and what our future plans are. So the study in Huntington's disease is still ongoing as we continue to monitor study patients now that they're off treatment. So participants in the study have been told if they were on placebo or branaplam, and if they were on placebo, they are now finished with the study. They all came back for one final visit. If they were on branaplam, they will have 2 to 3 more visits over approximately 1 year from the last dose that they had, which was for most people in August. And this is so we can monitor for resolution of any signs and symptoms that they have. So today, what we're going to do is provide you an overview of the observed safety findings and the decision to terminate development of branaplam. So we recognize the importance of sharing data with the community, and so we are planning what is called an interim analysis in the next few weeks, and that will allow us to present preliminary findings at the next available Huntington's disease conference, which is in April. And then, of course, we will share final data after the study completes this year. So if I can have the next slide. So as I mentioned, what led us to explore branaplam in people with Huntington's disease was the observation that branaplam lowers Huntington level. So Huntington-lowering therapies are among the most promising approaches in development for slowing the progression of Huntington's disease. And this is because it's well established that the mutant Huntington is the main cause of both disease onset and progression. And lowering mutant Huntington in Huntington's disease animal models provides support for slowing disease progression and improve symptoms. And the next slide. What distinguished branaplam from other Huntington-lowering drugs that had already been tested in people with Huntington's disease at the time we started was that it could be given orally. And this is important because the other Huntington-lowering agents being tested were either given as repeated intrathecal injections or a one-time injection directly into the brain. So branaplam was the first oral drug to be Huntington-lowering drug to be tested in people with Huntington's disease. So on the next slide, please. So why did we decide to start a clinical trial of branaplam in people with Huntington's disease? Well, we knew that branaplam had already demonstrated that it could get to key brain regions and lower mutant Huntington in mouse models. And second, before we started the study in Huntington's disease, branaplam had already been studied in babies and young children with SMA for more than 6 years, and it appeared to be well tolerated and effective. Before going into adults with Huntington's disease, we did a phase 1 study in healthy adults. And what we found in that study was that Huntington levels were lowered even after a single dose, and the findings of that study supported oral weekly administration of branaplam in adults. But before starting a clinical trial on Huntington's disease, we first discussed all of the potential safety risks with an external group of Huntington's disease advisors, as well as experts in various safety topics. And together, we came up with a protocol that would allow us to evaluate the ability of branaplam to lower Huntington in Huntington's patients, while also being on the lookout for the earliest signs and symptoms of any potential safety risks that might arise. So two of the key groups of people that we assembled to guide us through this are our data monitoring committee and our steering committee. And now it's a pleasure to turn it over to Dr. Leavitt, who is the chair of our steering committee, so that he can explain the roles and importance of both of these committees. If you can go to the next slide.
This slide's up, I think. Thank you, Beth, very much. Both the data monitoring committee and the steering committee are really critical components of ensuring that new drug trials, new clinical trials are run safely, and to ensure that participants are protected and that the studies are designed and run in such a way that we have the maximum opportunity to determine whether there's any benefit. The steering committee is generally a small group of investigators, disease experts, and/or patient representatives. And in the case of the branaplam trial, there were 4 investigators, all of whom were actively involved in Huntington's disease clinical trials. And the role of the steering committee is we're involved in study development, the development of the protocol, and how the study is conducted. And it's critical to understand that the steering committee remains blinded throughout the study, because often they're investigators, and in this case, we're all investigators participating in the study. The steering committee really is involved in setting up the study, designing how it's run, and ensuring that it's run properly, but we're kept blinded. The data monitoring committee is a really important, plays a really important role. This is an independent group of investigators. So these are not investigators involved in the actual running of study sites or seeing individuals, and they have access to unblinded data. And they play a really critical role in monitoring the trial for any potential risks, any safety concerns, and any potential benefits. And particularly the data monitoring committee for this study was composed of experts, not just in Huntington's disease, but also experts in understanding how the peripheral nerves might be damaged, and how, that's what we call a neuropathy specialist. So these are specialists who are involved in the understanding of the tests that are used to test for neuropathy and to study the peripheral nerves. So they play a role once the trial is begun, and they monitor the safety and the efficacy of the study as it goes, balancing the potential for benefit with any potential risks that might arise.
Okay, thanks. So together with our advisors, we then developed a protocol designed to detect and minimize all potential safety findings, including the neurotoxicity that we mentioned. So I mentioned earlier that we learned from some of our animal studies that branaplam might cause damage to peripheral nerves. Even though we had no evidence of such finding in our SMA study, we designed our first trial in HD patients to detect and minimize neurotoxicity. So one of the things we did was we used a staggered dose design, which allowed us to ensure that lower doses were safe before moving to higher doses. And I'll show you that in a minute. We also included several key safety assessments that were specific for monitoring the earliest signs of neurotoxicity. And Dr. Ramos will walk you through that shortly. And finally, as was just mentioned, we engaged with 2 neuropathy specialists for discussions on both the design of the study and review of data, one of whom was on our data monitoring committee, and one of them was just an external expert that we engaged separately. So if you saw the next slide. So this is the design of the Vibrant HD study. So the goals of this study was to identify a safe and well-tolerated dose of branaplam that lowers mutant huntingtin sufficiently in cerebrospinal fluid to expect a clinical benefit. The study was intended to evaluate 3 dose cohorts in a staggered fashion, as I mentioned, each with 20 people on branaplam, and 5 on placebo. So we started with a dose of 56 milligrams once weekly. Now, this is a dose that leads to similar exposure of branaplam as we had in our SMA study. So the plan was to review the safety data from the first cohort and then open the second cohort and start dosing people with 112 milligrams weekly. And unfortunately, as Dr. Ramos will now explain, we paused dosing and then terminated development before we had a chance to move to that second dose. So now I'll turn it over to you.
Thank you, Beth. The next slide. So what I'm going to do is I'm going to go over a little bit about what peripheral neuropathy is, and then go into how we were able to come up with a plan to detect this early and worked with the steering committee to come up with this plan. Now, peripheral neuropathy is a condition that affects the peripheral nerves. You can see in the diagram on the left that the peripheral nerves are those that are not part of the brain or spinal cord. And then these nerves are carrying information to and from areas to the brain. There are 3 different types of nerves within the peripheral nervous system. One is sensory, and another is motor, which affects motor, and another one is autonomic. It's a fancy word to use for those that we don't have total control over, and they primarily work with organs in our body and blood vessels. So these are the types of peripheral neuropathy that you can see from the nerves. You can have one of them, just sensory, or you can have 2 of them, or all 3 of them. The main cause for this type of neuropathy is some type of irritation or trauma or injury to the peripheral nerves. Examples that are most common are diabetes, folks that use alcohol for many years, low levels of vitamin, and then there's some medications that can cause this as well. The symptoms can range from mild to severe, and they can have a great impact on folks' daily activity, particularly in those that already have some type of an impaired neurological function. What do I mean? For example, if a patient or a person is having difficulty with numbness or sensation in their feet, and they also have some trouble coordination with feet, this would sort of amplify the problem and make it worse. Now, with peripheral neuropathy, many times it resolves on its own over time, but sometimes it may remain permanent. So what did we do in the study? We worked with our steering committee and experts to come up with a plan that we could detect these very, very early. This is not typical of a HD study, so it was something that we needed to make more in a unique fashion. So how it began was primarily through the neurological exam. This is when the physician, the principal investigator, was examining the patient, starting by asking questions. If they are having any symptoms, numbness, tingling, any abnormal sensation. A very comprehensive testing of vibration, temperature, and pain for all extremities was also being done, in addition to testing deep tendon reflexes. This is something when you go to the doctor and they use a hammer on your knee and you get the reflex, that type of testing, because what happens is in early signs for neuropathy, you will see a decrease and even an absence of this deep tendon reflexes, and muscle strength was also tested. These were all done from the very beginning at baseline, and they were tested quite frequently every month. Nerve conduction studies were also done, and this was a way to measure the electrical impulse that move through the nerve, both for the motor and for sensory. And these were also done at baseline so that we had some way to judge if there were changes later on. And additionally, we used sort of a different way of using NFL, which is the neurofilament light chain, which many of you have heard of in other HD studies using for neurodegeneration. But in this study, we were using this in the blood. We were testing this also on a monthly basis with the idea of finding any potential early injury or damage to the nerve cell where we would see an elevation in this marker. The next slide, please. So what happened and how did the signals emerge in this first cohort that we saw? Well, initially we saw some signals in 2 patients, and we were really keeping on top of all the patients and all the testing that we were done. That's a big part of the job that I was doing. And so we wanted to make sure that we were keeping on top of this particular finding or any other finding. And we alerted our DMC very quickly to let them know that this was something we were seeing. The DMC recommended to continue dosing, but keeping them updated on any new findings and the ones that we had seen. So over the course of several weeks, we were updating them practically weekly or every other week regarding any new findings we saw. There was a planned visit meeting with the DMC on July 28th, where we provided them more information that we had acquired. And at that time, they recommended temporarily suspending the study drug. However, they did not recommend stopping the study as they wanted to reassess the potential to restart the study drug at a later date. And this would be based on the information that we would receive when patients continued in the study to see if signs and symptoms that they were having were reversible, and also the potential benefit for the mutant Huntington lowering that we might see. We also spoke with our steering committee, and they agreed with this recommendation from the DMC, as they had noted that there was little tolerance for peripheral neuropathy, particularly in HD patients. The next slide. So what were the findings and concerns that we saw at this pause that the DMC reviewed? About a third of the patients had notable changes in their reflex. Remember I said that there could be changes when they decreased or they were absent, indicating early signs of neuropathy. About half of the participants had an increase in their NFL, indicating damage, as I had mentioned before. There were 3 patients who had experienced some changes with also measurable findings on their nerve conduction. So they had symptoms, but they also had nerve conduction findings when they were compared to their baseline. 2 patients had some numbness and abnormal feeling in their leg. 1 patient left because of it. However, both of these findings in the patients had cleared up. Next slide. So the actions following what the DMC had recommended with pausing, what did we do? The participants all stopped taking study drug immediately, but they continued coming in for their study visit. There was a Novartis sub-team, a small sub-team, which was reviewing unblinded data. That means that they could see who was on active drug and who was on placebo, so that they could fully assess the potential for any benefit, knowing the risks that we were seeing, and come up with a potential benefit risk for this situation. The Novartis sub-team recommended to discontinue the development of branaplam for the potential treatment for people with HD. And then this was endorsed by the DMC, the steering committee, and internal boards for Novartis as well. and communicated to all the investigators at the beginning of December. And the next slide goes into what were those key findings that led to the terminate the development. Many developed symptoms of neuropathy that could be from just symptoms, from their neurological exam, also from the nerve conduction study. We saw increases in the NFL, and also to our surprise, we saw some findings in the MRI where there was an increase in the volume size of the lateral ventricles. This is a fluid-filled space within the brain. These data are still preliminary. We are getting more information to better understand it, but it was something unexpected. However, we did not see clinical symptoms that could be attributed to these MRI findings. And then I'm going to hand it off to Beth, who will go over the decision-making with the benefit risk.
Thanks. Yes, so one of the important principles of drug development is the concept of the balance of benefit and risk. So to assess the potential benefit of branaplam, what we did was we measured how much of this first dose of branaplam lowered mutant Huntington in cerebrospinal fluid. And what we found was that branaplam actually, even at this first dose, did lower mutant Huntington protein levels in spinal fluid. And this was an important first demonstration that a Huntington-lowering drug that was given orally actually was able to get into the brain and then lower mutant Huntington as measured in spinal fluid. However, it's unlikely that lower doses or less frequent dosing of this dose would lower mutant Huntington sufficiently to slow the progression of the disease. So thus the benefit risk analysis led us to recommend stopping development of branaplam in Huntington's disease. And I can tell you this decision was both difficult and easy. So it was difficult because we all wanted branaplam to succeed and become available as a convenient treatment for people with Huntington's disease. And it was easy because the balance of benefit risk was clear. So before making this final decision, as was just mentioned, we discussed the results with both our steering committee and our data monitoring committee, and both committees were in full agreement. And since we have Dr. Leavitt here today, I'm going to pause here and see if he has anything to add from his perspective on the observations of the decision-making process. So I'll turn it over to you if you have anything you want to add.
Yeah, I think both Harry and Beth have done a really wonderful job of taking us through the decision-making process and the facts that led to this decision. And I think Beth put it beautifully when she said this was both an easy and a difficult decision. All of us involved in this have been engaged in developing treatments for Huntington's disease for many years, and we all want every possible effective therapy to get to patients as quickly as possible. That said, there's a basic principle in medicine of first do no harm, and we need to ensure that this risk of harm, if there is potential, has to be well outweighed by benefit. And this was a situation in which that risk-benefit ratio was not in favor of continuing. That was pretty clear. I would say that actually the community and certainly the investigators feel that Novartis did an incredible job of being on top of this study, ensuring that patient safety and participant safety was first and foremost. And the actions of very rapidly acting on these early findings, I think, was both appropriate and should be commended. So as seeing how this evolved, we're all disappointed that this particular approach is not moving forward, but I'm certainly comfortable and gratified that the appropriate measures were taken, and taken, most importantly, rapidly, so that other individuals weren't exposed to any increased risk. So I think that's pretty much what I'd like to say, and I'm happy to answer questions from my point of view if anyone has any.
Okay, Thanks, Lloyd. Before you do that, this is our last slide here. And so I just want to say thank you all for listening today. This is not the branaplam story that we hope to be telling you, but we think it's important to share it, and we look forward to actually sharing, more data in the future with you. So as you see here, a big thanks to everyone who participated in the study and to all the organizations shown here. When we couldn't have done this without you. So we'll stop here, and we're all happy to take any questions.
So much, Beth and Harry and Blair. I'll just echo Blair in that Harry and Beth did a great job sharing the Novartis perspective on the history of this. And of course, this is not the story that any of us wanted to hear, but it's very important to get it in front of the community. So thanks for being here to talk to us about it. And I'm going to start with some of the questions that are coming in. And the first one I'll pose to you is whether you have any thoughts on why branaplam seems safe in infants with SMA, but why it was not safe in adults. Is there any data that's kind of moving towards an answer to that?
I'll say a few things, and I'll see if Harry has anything to add. I mean, it is a great question, and it's one that we ask ourselves a lot. It's unclear. The two most obvious, answers are that either young children and babies with SMA are somehow more protected from this effect, or it could be that people with Huntington's disease are more vulnerable to the effect. Those are the two main things that we are thinking of. I don't know, Harry, is there anything else that you want to add to that?
Yeah, I think you covered, our thinking right now. I mean, it could always evolve, but that's what we were looking. We were surprised to get this finding, but that's what we're sort of thinking right now, at least of the hypothesis, that there's some more sensitivity in one group versus another.
I think that this also demonstrates a really important principle that's part of clinical trial design and development. And that is that, there's a progression of clinical trial design to ultimately show that a drug is safe and effective for a specific disease. And even though this is a drug that had been tested in individuals with a different disorder at a different age and different time in life, Novartis still had to go back to healthy individuals and do some testing. And that's what we often start our trials with is, can we show that this drug is safe and tolerated in healthy volunteers? But we always have to then do a safety and tolerability study in individuals with the specific disease, because there may be disease-specific sensitivities. And this is a good example of why we have to do these very careful, measured, scientifically valid studies, is because we don't know whether or not Huntington's patients will be more or less sensitive. And so when studies are done carefully, we learn from each step. And that's really the process by which scientific drug development has to go forward. We have to do things carefully. We have to do it according to these rules. And specifically in this case, it was done well, and it picked up some form of increased toxicity in patients with Huntington's disease. And hopefully, as we further examine the data, we may get some hints about why that may be. But at the end of the day, the study was done appropriately, and again identified this signal. And that's it's important for people to understand that while it's not the result we wanted, the study was designed specifically to ensure safety, and it identified that there was a safety concern. So the study did its job.
Beth, Blair, and Harry, I do want to just, echo what Leora said. Thank you very much for presenting what you did today. And I know people appreciate hearing more about the process that you all went through to learn about what was going on and the decision that was made, even though, as has been said, it was not the decision anyone wanted to make, but understanding why is important. A question that's come in that I think would be curious to hear if you're able to share, or if you can tell us, were you able to see what percentage of reduction you saw in mutant Huntington at dosing?
Yeah, this is a great question, and you know, what we can say now is that the levels that we saw of lowering were based on the preliminary analysis that we did during our decision-making process, right? While the study was still ongoing and blinded, and we were able to look at data quickly to make this decision. We are now doing this formal interim analysis where we will get, you know, validated data that we can share, and we will be sharing it in April. So I don't want to say the exact number now because it will likely change a little bit when we get our actual validated data. But it is at the lower end of what you would expect to be the minimum amount you would need to look for benefit, which made it very easy for us to recognize that if we were going to go to a dose that was a third the dose, a quarter the dose, a tenth of the dose, to try to get away from this, whatever is causing these signals of toxicity, we would then be probably out of range of Huntington lowering. We're not going to share a number today, but it is at the lower end of what you would want to see to be clinically meaningful, and we will share that number. Of course, we don't have all that much data either because we stopped the study we stopped dosing early in the study. So, we were supposed to look at Huntington lowering after 17 weeks of dosing. And when we paused dosing, we only had, a certain percentage of the 20 people on branaplam had actually reached 17 weeks. So it's a small number, but we will be sharing it.
Thanks, Beth. There's another question that is related also to Huntington expression. And if I'm understanding the question correctly, it's about whether we know anything about Huntington expression, about Huntington levels in other diseases like Alzheimer's or Parkinson's. And I think this relates to the story of branaplam and that it was identified as a Huntington lowering agent, even though it was developed for a different disease. So maybe that story would be interesting to folks. And if you know anything about Huntington and other disorders, it'd be interesting to hear about that too.
I guess I can address the role of Huntington and perhaps other disorders in as much as we know about it, which is not a lot. But we do know that the normal Huntington protein, so Huntington in the absence of the mutation that causes Huntington's disease, does play important roles in the development of the brain. It is critical for brain development. And we also know, and there is some evidence, that even in the adult brain, the levels of the normal protein play a role. So there is some evidence that if you increase the levels of the normal healthy protein, that may be protective, and if you decrease it, may be harmful. It isn't clear that that is a phenomenon or a mechanism that occurs in any other disorder. We only know from model organisms and model systems such as transgenic mice that if you take away the normal protein, they may be more sensitive to injury, for example. So that makes Huntington lowering a balance. We want to decrease the abnormal protein in Huntington's disease while sparing as much as possible the normal. But we hope that we'll be able to find a balance that provides benefit. It's not clear in this particular case whether the safety signal or the safety concerns are related to Huntington lowering, or whether it's another effect of the drug that isn't related to its what we would call on-target effect or its intended effect. We just don't know.
So I can add a little bit to that. So we mentioned earlier that that we had our first glimpse of potential neurotoxicity came from a dog study. We hadn't seen it in our mice studies, and it turns out in dogs and in mice, branaplam does not lower Huntington levels. Right, it's a very specific effect on the splicing of the human form of Huntington. So we can see it in mouse models where you actually add the human Huntington gene, so that it is actually what you see in humans, but in a normal mouse or in a normal dog or non-human primate, branaplam doesn't lower Huntington. So we actually don't think that the neurotoxicity that was seen was due to Huntington lowering itself, because we see it in species like dog where Huntington levels were not affected. But it could well be, as Blair was just saying, that the normal Huntington protein is neuroprotective. So it could be that could be one difference between the SMA children who have 2 copies of the normal Huntington. Perhaps that offered some sort of protection to them compared to people with Huntington's disease that have one form of the mutant Huntington protein and one of normal, that perhaps made them more vulnerable. But that's still to be determined.
Yeah, I think that maybe gets also at the question of, what is causing this peripheral neuropathy, which I think is a tough one to answer. But I think some of what you just said, Beth, is maybe a helpful way to frame it.
Well, we know what's not. So we know it's probably not due to mutant Huntington. And there are a few things we're exploring, but we have more data to analyze, and discussions with experts to try to find out. It is probably something that is, as Blair said, off target, not due to the effects of branaplam on the Huntington mRNA itself.
I want to ask a couple of questions actually that are related a bit to the study design, just for some clarification. Someone was asking again, what phase trial was this? And the second question would be, again, who were the participants in the trial? What were the eligibility requirements? What stage of HD were they experiencing? Just a little bit more about that trial design. What phase was it, and who were the participants?
Yeah, there may have been some confusion because we did talk quickly about a phase 1 study that we did. And that study was a single dose in healthy volunteers who were adult. And that was basically the only inclusion criteria. The data that we talked about today came from our Vibrant HD study, which was a phase 2B study. And it included people with early stage Huntington's disease. So these were people that had to have, genetically confirmed carriers of the Huntington's gene mutation, and had to have a total functional capacity of, I think it was between 13 and 8. So it was people with, who had Huntington's disease symptoms for several years, so people at the early stages of the disease. So that's the study that we talked about today. We did mention briefly the healthy volunteer stage 1 study. So it was early stage Huntington's disease.
Thank you so much for that clarification.
So I'm seeing a question here that I hope I'm interpreting correctly, but also I received another question through our webinar's email address, which is webinar@hdsa.org, and it's about reversibility, really, and of the peripheral neuropathy that you've been talking about. So it sounds like because of all of these safety measures in place, because of the trial design that you just spoke to, designed with the low dose first, these frequent checks for neuropathy, that the actual number of individuals who took branaplam was quite low. So I'm wondering if you're able to comment on what those numbers actually looked like, and whether the peripheral neuropathy symptoms or those side effects did clear up for those who experienced it.
Beth, I can take on, and then if you want to add anything else. So currently, and that's correct, with the way the design was done, was sort of a step approach to detect these things early. In fact, part of it was to make sure that if there were signs, symptoms that are confirmed, that we would even stop treatment early in those patients. What I can say is we're still looking at the data because we don't have everything in yet, but at least it does appear, I know I had presented in the prior slide that there were 2 patients that had some symptoms that seemed to have improved, but we're looking at more data that's coming in, and that requires patients coming in for further visits because they were farther along or less farther along. So we're still looking at that data so that we can have a better idea on reversibility. And we're looking at it as a fact of symptoms, findings that they could have on their neuro exam, and their nerve conduction. So we're looking at it sort of a 3-pronged approach of what we're seeing with them. And that takes a little bit of time, but we are looking at that. I don't know, Beth, if anybody else wants that.
Yeah, no, and we will be able to share some of that. And so as Harry said, the data is still coming in. You know, we stopped the study pretty quickly, so we need to have people come in for their follow-up assessment so that we can look at both the, all of the signs and the symptoms. And we will show some of that data in April so that we can put everything together, whether we're looking at, blood levels of neurofilament NFL, which was the earliest thing that led us to think that there was maybe something going on, all the way up to the symptoms. So we'll have more to say about that. But this is why it's important for people that are in the study to continue, coming in for visits, even if they are not personally feeling any symptoms. There may be subtle things that can be detected in some of the other assessments that we do that are, sort of what they call subclinical, where the patient doesn't even realize it, but perhaps we can pick something up in one of these very sensitive measures and then watch the recovery of that. So stay tuned.
Thanks for that, Beth. And I really appreciate what you just emphasized, which is the importance of staying in a trial, even when the drug that was being studied has been stopped, because there's a lot that is still being learned and a lot of important information that's being gathered. And I think that's something we've heard emphasized before. Blair, I think you even mentioned that a little earlier, but it is something that is so important. You're still learning so much that you're going to be able to share as you finish with the people going through the process right now. So thanks for emphasizing that part. A question that came in, and I'm curious what y'all think about this. Is it possible that another route of administration of the drug would have less or no side effects?
I mean, theoretically, we've only ever looked at it orally because it is an oral drug. I don't know that we would be able to get around that, because the target, or first, Huntington is everywhere. So really, the beauty of a drug such as branaplam is that it targets Huntington protein everywhere, and certainly you would want to at least have it in the brain. And I can envision another route of administration that would be the answer to this.
Yeah, I think it's a really interesting question, not necessarily directly applicable to the branaplam situation, but one, if we take a step back and just think about Huntington lowering therapies in general. And it is a question that we all have to ask ourselves and think about: is there a benefit to lowering Huntington exclusively in the CNS, or is there a benefit to total Huntington lowering? And the answer to that is we don't know yet, which is an optimal approach. And we need to take and learn as much as we can from every one of these studies to ultimately design the best therapeutics for Huntington's disease. But it is, I would say, a very open question in the drug development and Huntington's disease research community as to whether it would be better to only lower Huntington in the CNS. We don't know.
I think that also speaks a little bit to another question we got about whether branaplam is an example in terms of other mRNA splicing modulators, which are in development in from other companies and in preclinical development in different ways and in academia and industry. So I wonder if you're able to comment on, the safety or the specificity of branaplam and in regards to other ones in development. I know that's tough to do from a particular perspective, but maybe, what can we learn from this in terms of how the field moves forward into an effective therapy?
Yeah, so I will say, so, obviously, at Novartis, we have only tested branaplam in people. And even in our preclinical animal models, we have only tested branaplam. So it's hard to say anything about other splice modulators. What we can say is that, as I mentioned, we see this particular adverse event on peripheral nerves in species in which branaplam is not lowering Huntington. So I don't think that this should be in any way an indictment of all Huntington lowering compounds or all splice modulators. It is, there may be something that could be shared with other splice modulators, but not necessarily. And I think that there would be a way of developing a splice modulator that didn't have this effect. I don't know if anyone else wants to add anything to that.
No, I think that's a really good summary, and I think the fact that this toxicity was seen without Huntington lowering in other species is an important one, and it is I think a cause for some hope for these types of approaches, Huntington lowering in general, for the future. So drug development drug development for neurologic disease is a very difficult task. And what's critical is that it's done appropriately and that we learn. And I just, again, have to give credit to Novartis for sharing the data and for doing appropriately done studies, because this is how we learn. And again, this is a step towards ultimately developing effective therapies.
We have a question about how branaplam lowers mutant Huntington levels. I'm not sure if that, because we addressed the question of kind of Novartis looking at the data in terms of percentage of Huntington lowering and risk benefit, but maybe that's a question about the method, the splicing and what it does actually to the gene or to the RNA.
Yeah, if it is about that, then we didn't show our cartoon of that just to spare people time on that, but we didn't talk about the mechanism too much. But it is what's called a splice modulator. So what branaplam does is it changes the way the Huntington mRNA gets spliced together, and it ends up changing it in a way that causes the mRNA to just degrade and then not produce the Huntington protein. And it's a similar mechanism for what it does for the protein that's involved in SMA, and there it does the opposite. It actually stabilizes it. So that is the mechanism. It's a splice modulator on the mRNA itself. And obviously branaplam is not specific for the Huntington mRNA because it also does something similar on the SMA particular gene that is involved with that disease.
I think I see one more question where you also touched on in terms of looking at preclinical models, and I think that there's they're based on the data from preclinical models is what led you to put all these safety measures in place in humans.
Well, if I could just comment on that, the interesting thing there is that the study where we saw these changes and all that, it was a 52-week study. So usually in drug development, you like to have, assays or even animal studies where you can give an animal a dose of a drug and wait a week and see something, or maybe you dose them for a few weeks. In this case, it took many weeks for anything to appear. And as Harry showed in our Vibrant HD study, the earliest thing that we saw was a change in NFL, and that took 9 weeks. So it's not the kind of thing that you would pick up in a typical very quick screen. I mean, you have to do long-term studies to pick up these changes.
Beth, Blair, Harry, again, thank you so much for joining us today and talking about what has been learned from the study, and for answering all the questions, and for really emphasizing how important it is that we don't just look at drug development and even just science as an outcome that is based solely on success. There is so much that is learned in the process of doing this, and I think it's been emphasized, and I hope people are hearing this too, just the importance of how early this was identified because of the things that Novartis had built into the study to check for safety, to check for these kinds of things. And again, not the conversation that any of us wanted to be having today, but I think there's a lot to take away from this. So really appreciate your time and the conversation, sharing all of this information. So thank you all so much for that.
Thanks for having us.
Yeah,
And thank you to the HDSA for giving the opportunity to get this information out. I appreciate it. You guys do a great job.
Absolutely. We really appreciate your time, and we appreciate everybody's time. Thank you very much for joining us live, and hopefully you will share this recording with others who are interested, and will join us for our next HDSA research webinar, which will be advertising on all of our social media and email channels when we have something planned. So thank you, everybody, and have a great rest of your day. Bye, all.
Bye.
Thank you.